Hi doctors, how are you? Welcome to week number 7 and free weekly quiz. In this quiz, we are going to discuss about oral pathology part 1. But before we discuss it, the AFK exam result was released 2 days ago. Our full course success rate was 92% of all the doctors did the course with us. If I'm discussing about doctors who scored more than 70 in the mock, it will be 96, which I do not like this way. This, I think, is deceiving way of giving you the information. But for all the doctors who did enroll in our course, in our mock package, we have 92%. I will discuss this success rate in a separate video and discussing the value of this, what we are doing here. Because like tonight and Sunday, I'm giving you this. In the same day in the morning, we're doing 25 questions for doctor enrolled in the mock package, enrolled in the full course. Let's go back to oral pathology. In oral pathology, it's extremely important and annoying topic, honestly. When you study pathology, you feel like you are diseased now, you are infected now. So for oral pathology, you need to be smart when you study this one. Any condition, you hear it, you need to give 3 tags. You need to give etiology, you need to give clinical presentation, you need to give management or treatment. This is very, very important. If you don't have this 3 major information about each condition, you are not 100% sure about the answer for the question. The question for oral pathology usually come in 3 categories. The easy category when asking about the etiology, asking you about management, asking you about like the dose for this condition, then virus release responsible for this disease. This is the easy one. The second type, when he's correlating between clinical picture, histopathological exam. So patient have this clinical picture, we did a swab, we did biopsy. What you will see in this histopathological examination. So you don't see the name of condition in the question, you don't see it in the answer, but you should know it. So think about it's a mystery. Once you understand the mystery, you can pick the answer. Third, and this is the most difficult one, honestly, when they combining oral pathology with medical management, sometimes with surgery, sometimes with anatomy. This is really annoying kind of question, but this is not the most common one. The most common one is type 2, like the second correlation between clinical presentation and histopathology. Let's not waste your time and go to the first question. This question is saying, a biopsy from a white lesion on the buccal mucosa show hyperkeratosis, so tooth rich, and a band-like lymphocytic infiltrate at the epithelial connective tissue interface, so in the basal membrane. What is the most likely diagnosis? So this is classical question giving you the clinical presentation, asking you what is the diagnosis for this one. Leukoplakia, oral lichen planus, chronic hypoplastic candidiasis, discoid lupus erythematosa. And this is classic question of oral lichen planus because this condition is a chronic T-cell mediated immune disorder affecting stratified squamous epithelium. This is coming from Neville for oral pathology textbook. The key histopathological feature, this will save you question. Trust me, doctors, you need to memorize it. And I would like to study this in a horizontal direction, meaning you are going to study vertical, and then after you study vertical, you're going to go with this word. Okay, what are the conditions we having this? Oh, how I can differentiate between this condition and that condition. And if you add the management, perfect. You have now a solid horizontal understanding of pathology. So the key histological feature for this one, hyperkeratosis, which means white, thickened keratin layer, giving this white presentation for this condition. So tooth rich, which means irregular epithelial projection. So we have the junction between epithelium and basal membrane, it becoming like this way. And we have band-like lymphocytic infiltration, which accumulation of T lymphocyte because it's a T-cell mediated immune disorder at the epithelial connective tissue junction. Basal sheath degeneration, which is destruction of basal keratinocyte. And this is the clinical presentation for this one. This is a reticular form, which is the most common one. As you can see, it has Wickham's trial. Now you'll stop me, man, like AFK is that like with no picture. Why are you giving me picture? And this is a very good like notes from you. This is very important. Trust me, studying oral pathology with no picture is almost useless. I know this is a strong statement, but trust me, studying oral pathology with no picture, it will make your life so difficult. And this is why most of us studying oral pathology again and again and again and keep forgetting the information. You must correlate between the information and picture. If you don't have clinical picture to correlate to this information, trust me, retention rate will be very, very low for this one. So this white, they call it Wickham's trial, which is lacy pattern of white on the buccal mucosa, most likely, and most likely it will be bilateral with familial history. This is due to CD8 T cells, so lymphocyte T cells, specifically CD8, which is going to attack basal keratinocyte, lead to chronic infiltration and inflammation, and epithelial damage clearly correlate with white stria, which we call it Wickham stria. Let's see our other option. So this is the correct one. Leukoplakia. Leukoplakia is a white lesion, and I don't know what's happening here. So I don't see anything related to infiltration of T cells. I don't see any etiology leading to this one. So leukoplakia is not a diagnosis by itself. It's a white lesion that I cannot correlate it to any reason. This is what we call leukoplakia. White plaque, which is clinical term, you see here, is not a diagnosis. Chronic hyperplastic candidiasis, this is fungal infection. We have candidal hypha coming in the histopathology, and epithelial hyperplasia. No sawtooth, rete ridge, or lymphocytic band. Discoid lupus, this is autoimmune, yes. Perivascular inflammation, basal membrane thickening, but this one lacks the classic sawtooth pattern. So this one, yes, it has something to do with immunity, but it has no this pattern of the sawtooth, and this is the basal membrane junction and between the epithelium and the connective tissue. The answer here, oral leukoplakia. Oral lichen planus. Next question. A lesion present as a mixed red and white patch on the lateral tongue. What is the most appropriate description? So here we have a mixed lesion, red and white. So leukoplakia, white, erythroplakia, red, erythroleukoplakia, yes, and hyperkeratosis. So this is easy question discussing about the description of the name. So erythroleukoplakia is defined as a mixed red and white lesion of the oral mucosa that cannot be clinically or pathologically characterized as any other disease. Again, erythro and leukoplakia, they are just description. It's not a diagnosis. So here in this question, we have combination of the erythro, which is red, which is epithelial atrophy and high dysplasia risk, and leukoplakia, which is white area due to hyperkeratosis. What are the common location for this condition? Lateral of the tongue, we have high risk site for this one. Floor of the mouth, also this is very dangerous one. It has high malignant transformation potential, often show moderate to severe epithelial dysplasia or carcinoma in situ. So what's the difference? Carcinoma in situ is dysplasia exclusive to epithelium, is not invading inside the connective tissue. Once it invades inside the connective tissue, this is, we can consider it in a way squamous cell carcinoma or different form of squamous cell carcinoma. But to start with, erythroplakia, leukoplakia, erythroleukoplakia, we consider it have high malignant potential unless we do the histopathology and come as carcinoma in situ. And this is how it looks. So this is erythroplakia. So I hope you can see the white and red lesion. So we have white and red lesion, and in this location is dangerous, floor of the oral cavity. Why this location is dangerous? Because this location has thin, non-keratinized epithelium. It's very difficult to do biopsy here and to do surgical excision, has high recurrence rate, and this is very close to the amazing submandibular lymph node and has high potential of recurrence and metastasis. So this is very, very important to follow up, specifically old age, long-standing lesion. This is very important to follow up with this patient with incisional biopsy to understand what's happening. So this is erythroleukoplakia, mixed lesion, leukoplakia white only, erythroplakia red only, hyperkeratosis, it's white, but it's not related to malignancy. This is thick keratin layer. This thick keratin layer might be having a lot of reasons. Might be candidiasis, might be due to trauma happening in this area, but it's not having any malignancy tendency for any patient. You just need to remove etiology and follow up with your patient. Next question. Which of the following condition is characterized by subepithelial cleft formation histologically and present clinically with desquamative gingivitis? You remember erythroplakia, leukoplakia? Same for desquamative gingivitis. This is not a diagnosis. This is not a disease, sorry. This is a clinical presentation which can happen in 5 conditions. If you know the 5 conditions, please write in the comment section. I hope someone can give me all 5 conditions. So let's go back to question. So here we have condition with subepithelial clefting, and we have desquamative gingivitis. Pemphigus variegalis, mucous membrane pemphigoid, lichen planus, or erythema multiforme. So let's understand this one first before we discuss about pemphigus vulgaris, mucous membrane pemphigoid. Both conditions are autoimmune conditions, leading to problem in the connection between either the epithelium itself or the epithelium and the basal membrane and the connective tissue. So if the problem happened in this mesome, which is connecting the epithelium together, so we are going to end up at what we call pemphigus vulgaris. We have here intraepithelium bulla, which means separation of the epithelium in this area. This intraepithelial bulla will be thin. Think about it. The thickness of epithelium is this. Think about bulla inside. So we are going to have very fragile bulla, which going to be ruptured if you apply any pressure, which we call Nikolsky sign. This is what we call pemphigus vulgaris, autoimmune inside epithelium, intraepithelial clifting with bulla, thin and fragile. The other one, we have problem in the connection between epithelium and connective tissue and the level of hemidesmosome. In this case, we call it mucous membrane pemphigoid or bullous pemphigoid, as you can see in this area. Think about it. This one will have thicker bulla. Yes, it might be positive to Nikolsky sign, but most likely it will be negative for Nikolsky sign. Going back to question, here we have subepithelial cleft and present with this comitative gingivitis. So this is clinical presentation of mucous membrane pemphigoid, which is chronic autoimmune subepithelial blistering disease affecting mucous membrane, subepithelial cleft separation below the epithelium, autoantibody target basement membrane zone BMZ lead to epithelial separation from the connective tissue. This comitative gingivitis, which is erythematous and peeling gingiva, it can happen in 5 conditions: lichen planus, which is severe form of lichen planus, lupus, mucous membrane pemphigoid, pemphigus vulgaris, and erythema multiforme. These are 5 conditions where we might end up by this comitative gingivitis. So this comitative gingivitis, think about it as erythroplakia, leukoplakia is not a disease. It's just description of what's happening here. How we are going to deal with such condition? You need to give corticosteroids to deal with the condition, except for amazing erythema multiforme. The management for erythema multiforme, the most important management is to stop the offending drug if you can catch this one. So this is mucous membrane pemphigoid, autoimmune blistering disease, subepithelial, pemphigus vulgaris, intraepithelial cleft, acantholysis. In which layer this acantholysis happen? I hope someone can answer me. Cleft is within the epithelium, and this is very difficult condition and life-threatening. If you don't deal with this one with systemic corticosteroids, your patient might be dead soon. Why? Because the patient will lose fluid, because like connective tissue is exposed, man. So now he was losing the fluid from everywhere, so he will go dehydration, and he might be dead. So this is very dangerous condition. You need to deal with it as soon as we could. Lichen planus, immune mediated, we just discussed this 2 questions ago. Erythema multiforme, hypersensitivity reaction. Which type of hypersensitivity reaction? 3 or 4? I hope someone can answer me. And this has target lesion and ulceration and no specific subepithelial cleft. So I hope you can catch the pattern. So in the question, you will not have all the clue. He will not tell you Nikolsky sign. He will not tell you the lesion on the eye, this female old patient. No, he will not give you all the information. He will give you 2, 3 information maximum, and then giving you differential. So you should understand how you can navigate and answer your question. Next question. Which of the following lesion is strongly associated with Epstein-Barr virus and show ballooning degeneration of epithelial cell histologically? Oral helicoplakia, herpes simplex, verrucous vulgaris, or squamous papilloma. This is kind of classical clinical presentation of oral helicoplakia. So this is how it looks. So most likely it happened in immunocompromised patient. Immunocompromised patient might be HIV infected patient, might be patient having organ transplantation happen, so he's taking some immunocompromised, not immunocompromised, he's taking some medication to control his immunity, not to end up by rejection of this organ. Please listen carefully to the next, because this is confusing part, but I hope we can make it clear. So if the question telling you this is happening, and the question telling you this clinical presentation about immunocompromised patient, this white lesion cannot be wiped off. Cannot be wiped off. And this is the definition of oral helicoplakia due to Epstein-Barr virus. Nice. What if the question telling you it can be wiped off? So what is this? Read here with me. May be secondary infected by Candida albicans. So it might start as oral leukoplakia, but because this patient is immunocompromised with bad oral hygiene for sure, he's not in a good mood to take care about his oral cavity and oral hygiene. He's immunocompromised patient now. So sometimes it ends up by super infection. In this case, yes, it might be wiped off. So again, oral leukoplakia cannot be wiped off. If the question describing this and telling you it can be wiped off, so this is the key for this mystery. Oral leukoplakia treatment is none. Treatment is none. If the condition, so what do you think? The patient has this condition and end up by super infection. So how are you going to deal with him? You're going to tell him, no, I will not deal with you. No, you're going to give him topical nystatin. Amazing. So oral leukoplakia strongly associated with Epstein-Barr virus. So to understand this concept, this patient immunocompromised, Epstein-Barr virus is present inside his oral cavity. It will do nothing unless he's immunocompromised. It will lead to this problem. What else we can correlate to this? The same concept is Kaposi sarcoma, herpes simplex number 8. So this herpes simplex is like it's present inside the oral cavity, but it's not working against you because you have good immunity. Once it's compromised, might end up by Kaposi, might end up by this, might end up by fungal infection. So this is very common for immunocompromised patients, particularly immunocompromised patients. Hyperkeratosis, thick keratin layer, this is why it's white. Acanthosis, which is epithelial thickening. Ballooning degeneration of epithelial cell and presence of Epstein-Barr virus confirmed by cytohybridization, which is type of biopsy. And for this condition, what is the type of biopsy you are going to do? I hope someone can answer me. So it looks white, corrugated, which is hairy plaque, typically in lateral border of the tongue, and most likely it will be bilateral and cannot be wiped off and not pre-malignant. I know most of us as a dentist think about this condition and like plans to be malignant, pre-malignant, which is not. Both conditions are not pre-malignant. So don't think about this one to be a pre-malignant condition. Herpes simplex, this is due to infection of herpes simplex, multinucleated giant cells and vesicle. We don't have Epstein-Barr virus in this one. Verrucas varigalis, this is papillary surface, coleocyte, no ballooning degeneration, and this is related to different clinical presentation. Please, this keyword will save you in the exam. You need to understand this keyword correlated to clinical presentation, correlated to the condition, correlated to picture. Boom, trust me, you will see huge improvement in your performance in oral pathology. Squamous papilloma, this is herpes virus simplex again, finger-like projection, and no Epstein-Barr virus. Again, doctors, just understanding, just memorizing the name of the virus, memorizing the etiology will save you a lot of questions in the exam. Please do it, write it. Do whatever you want to do it, but and when you read the condition, you can give me the etiology, you can give me clinical presentation and management for any condition. Whatever you want to do, just do it and answer your questions. Last question for today. Which of the following oral lesion has the highest risk of malignant transformation? Homogeneous leukoplakia, erythroplakia, frictional keratosis, linea alba. So let's understand the problem here. Erythroleukoplakia, which is red, we just discussed this 2 questions ago, is defined as fiery red, fire, like it's like velvet red patch that cannot be clinically or pathologically diagnosed as any other condition. This one has the highest malignant transformation rate. Why? Because it shows 70 to 90% severe dysplasia. You remember this dysplasia? We said like the cells will become abnormal, the cells become dysfunctional, like the cytoplasm ratio is very bad, it's not working. And it's show like malignancy, either to be carcinoma in situ, exclusive to epithelium, or invasion carcinoma, which is going to invade inside the connective tissue. Why it become as red? Because epithelial atrophy. Epithelium here almost always gone. We don't have epithelium. We have connective tissue. So underlying vascular became visible, and common high-risk site is the floor of the mouth and ventral and lateral tongue. Why floor of the mouth? Again, non-keratinized, soft tissue, very difficult to excise, high chance of recurrence, and metastasis to submandibular lymph node. So if you would like to go by order, erythroleukoplakia, erythroplakia, erythroleukoplakia, leukoplakia, and malignant potential. Friction keratosis, linea alba, this is benign reactive. What meaning of reactive? It has trauma. You extracted the lower 6, upper 6 is like over erupting, hitting the residual ridge. It will end up by this. Patient is stressed, like yourself studying for AFK, doing this while eating, ending up by linea alba. So this is the meaning of reactive lesion. What is the management? Remove etiological factor. Ask the dentist to relax. I hope he can relax. Or ask this patient to have some flipper in this area to control this trauma happening from the opposite side, and then follow up with the patient. So erythroplakia, red pre-malignant lesion. Homogeneous leukoplakia, this is white. Hyperkeratosis, yes, it has potential. Don't understand from what I'm saying it has no potential. It has. But compared to this one, no, this one has higher malignant transformation potential. Friction keratosis, this is reactive lesion, no malignant transformation, chronic irritation. Linea alba, normal variant, white line on the buccal mucosa at the level of occlusion. So the answer here is erythroplakia. I hope this short quiz just gives you the idea about how to study oral pathology. Again, oral pathology extremely important. If you would like to know what are the most important chapter, would be white, red, cyst, vesicular bolus, and ulcer. If you don't study these topics, do not go to the exam. These topics are extremely important and will give you a lot in the real exam. Thank you very much, and see you next week with dental material.